Hello and welcome back to the Signal Sleuths series. This is a playlist of EMG cases where we try to, so to speak, crack the case. I started to get a little bit creative here and getting a little wild with the AI images, but there's some loosely guided theme in terms of what this diagnosis is related to that right there. All right, here we go. This is actually not an EMG case in terms of pure nerve conduction studies and needle EMG, but it is related, and more on that in just a moment. Here's the background. It's a 35-year-old male, does a lot of computer work, right-hand dominant, having bilateral forearm pain. It is mainly in the lateral elbow, and of course, immediately all the typical differential diagnosis of lateral elbow pain comes up. Of course, tennis elbow is one. There's not that many other structures in the lateral elbow to go wrong. I mean, you can get arthritis on the outside of the elbow. You can get a plica. Sometimes if you had a specific injury like a fall, you can get an osteochondral defect. You can get posterior lateral rotary instability. None of these apply in this patient, and this is in the EMG playlist, so you better believe something's coming up. Triceps tendinopathy, that's a source of referred pain. Cervical radiculopathy, a source of radiating pain. Well, there's one specific diagnosis that's missing on this differential diagnosis, which we are going to talk about. We actually had him here for ultrasound, and well, what are we looking at? Radial recurrent artery, right? Also known as the leash of Henry. Pull up my pointer here. So when we have the brachial artery coming down into the radial artery, there is this branch that turns around and goes back proximally, the radial recurrent artery right there. Why is that relevant? Well, it wraps right around this branch or bifurcation. The radial nerve proper comes down, and it has a superficial sensory branch going down to the anatomical snuff box, and it has the deep radial branch, which then becomes the formal posterior interosseous nerve. And that radial recurrent artery wraps right around. It is, as I said, also known as the leash of Henry. This is kind of the nickname for it, and it can potentially be a source of nerve entrapment. And here's where this case differs from others in the playlist. There is no EMG. The specific elbow surgeon that referred this case knows that many times radial nerve entrapment, posterior interosseous syndrome, EMG is completely normal. And as ultrasound becomes more and more commonplace, this particular surgeon wanted to know about the ultrasound. So here we are. We are superficial here, deep here, lateral is over here, medial is over here, as this is the right upper extremity. We have the superficial branch there, the deep branch, which to me looks, well, larger, enlarged, certainly compared to the superficial branch, but also to the recurrent radial artery, which is underneath it. I don't have Doppler on there, but that's what it is. Well, I did do Doppler. I also did compression. Don't have it as a picture. Now, in this case, as we scan slightly more distally, here is the deep branch, and it stays enlarged. The recurrent branch goes underneath. And here is the needle coming across. Now I drew on top of it superficial branch, deep branch, artery. That's a little better one, as the injectate right there, that dark area, is starting to fill in the fascial plane right in between the superficial and deep branch right there. That's where you want fluid to go. That's where hydrodissection and things like that go. You don't want it ending up balling up in the muscle. You want it in that fascial plane. So that was the right side. He had symptoms bilaterally, and this, as of now, would be a pretty boring case. So why is this different? Why are we showing you this? Well, you're going to find out right now. So superficial here, deep here, lateral is on this side, and medial is on this side, since it's the left side. Here is the artery, deep radial nerve right there. As we are starting to move distally, this artery is starting to appear a little bit more on the side. I provided compression. I do have one snapshot at least of where the artery did compress when using the probe. As we start going farther down, we start to see that this artery goes right on top of the deep radial nerve. Again, deep radial nerve is enlarged compared to the superficial, right near the beginning of the supinator here where it's going to enter in, and that's a common site. Here is the injection that we did. Deep radial nerve is here, superficial here. The black is the injectate, clearly avoiding the artery that is very obviously above, more superficial, going over the deep radial branch. And then this is afterwards when there's often a little bit of air bubbles in the injectate. So when we finish the injection, that last little bit comes in, those air bubbles become very hyperechoic all along here, clearly encircling the deep radial nerve and the artery as well, even pushes on the superficial radial nerve a little bit. So that patient did get a little bit of anatomical snuff box numbness with this injection. Why do we do this injection? Well, it's diagnostic and therapeutic. If they have deep radial nerve entrapment and we inject lidocaine, well, their symptoms are going to get better in the lateral arm. But when we put in cortisone, it can potentially relieve that inflammation and be a full treatment. So it's not just diagnostic, it's therapeutic. But if the cortisone works and wears off, then they may be a candidate for surgery. So what is going on here? This is the loosely themed first slide, the leash, sort of. Well, it's obviously a leash. Which situation is more common? Does that radial recurrent artery go over or under? And in this case, was that leash the cause of the symptoms, the atypical situation where one goes over and one goes under? And if so, is it because the leash of Henry is over and compressing the PIN, or is it the opposite where it's under and pulling and hooking it and tethering it, kind of like this dog leash? When you pull on the dog leash so the dog doesn't run forward, is it tethering the deep branch? This is where, well, some of the unknowns come into play. Quick little FYI, the other picture in the title slide was very kind of wild. Asked AI to create something with radial, something with nerves. So the hand that had the radially outgoing nerves, which was kind of weird, and in impressionism style is what I was going for at that time. I did like that one, but I put in leash of Henry, recurrent radial artery, digital art, and this time I asked Dolly, and quite literally, this is what I got, which is, yeah, a little scary and kind of bizarre. I have no idea why a strawberry is in here and maybe some kind of turnip or some root vegetable there. I'm guessing, and I kid you not, this is what I put in: leash of Henry, recurrent radial artery, digital art, Dolly. This is what. Why a unicorn and some rainbows? I have no idea, but maybe the leash. Maybe Henry's the name of some unicorn somewhere on the internet, and it was kind of tethering or leashing the unicorn. I removed leash of Henry, and I got this really bizarre art as well. Never mind the arteries external to the body. There's 6 fingers here. That's another thing that's interesting. But they did get some things right. There's some overlapping here where there's a potential, leash of Henry with recurrent radial artery. Scary stuff. All right, back to the case. What is assumed here? Traditionally, what we learn in medical school and across elbow and orthopedics specialties, we assume that the predominant pattern is that the recurrent radial artery crosses underneath or deep to below. In this drawing, the radial artery comes down. This is drawn a little bit weird. It's a very long recurrent radial artery that then goes across, but goes deeper underneath. This is the superficial and then the deep branch of the radial nerve. Interestingly, I just did this case today in terms of the ultrasound and the injection, the second part. We did one arm a couple months ago, and he came back for the second one today. About 6 months ago, as of the date of this video, July of last year, there is a nice review article in Skeletal Radiology about all the different patterns of this exact situation. To get your bearings here, this is brachioradialis. That's the brachialis, extensor carpi radialis longus, and of course the radius bone. There are 3 potential patterns. Superficial branch and the deep branch are target here. The artery can either go under, it can go over, or it could just not be associated with it at all. But then if you really dive into the anatomy, there are separate branches here. There's a muscular branch here, and sometimes there's the pattern where the muscular branch then goes over the deep radial branch if you scan further distally, and if you have a good enough ultrasound that can see that bifurcation. Or it goes under, or it's just not quite associated somewhere far away. And what they found, as in many anomalies of the body, about 15% of the time it is anomalous, but about 85% of the time, The pattern was that the recurrent radial artery did indeed cross below or underneath the deep radial nerve. This situation right here. That muscular arterial branch, if you can see it on ultrasound and you scan a little more distally, pretty much that time, almost all the time in this small sample size, it actually had a little wrapping over, but it was farther down. And I'm going to give some examples. There we go. Sorry, this is gross anatomy. Here is our radial nerve that bifurcates into the superficial there, the deep, and then the recurrent radial artery travels right underneath it or deep to it right there. Sorry, my pointer is red. Should probably change it here. That is the radial artery, of course, traveling under. I drew it like it's traveling over. Here we go. When we zoom in, the superficial sensory branch here is the deep radial branch, and that recurrent artery right here traveling underneath. But there's this other branch right there, that muscular branch that does, well, maybe not drawn so well here, but this does go superficial over the deep radial nerve. But the supinator is right here. That nerve is diving right down into the supinator. So this muscular branch that's right here does not necessarily play as much of a part as the recurrent radial artery in terms of a site of entrapment. Now, on MRI, these structures are quite small. I'm going to go back to my red pointer here. Recurrent radial artery right here, deep to the deep radial nerve branch in this situation. And over here, that's the muscular branch. Actually, sometimes I've been lucky enough to catch that on ultrasound because it does go longitudinal right under the probe. And if you have Doppler on, it just lights up straight across the screen. So I have been able to see that sometimes. But this is the predominant pattern right there. Here's an ultrasound version, deep radial nerve here, and this is the anomaly where the artery actually travels over it instead of under it. And that's what we saw on one extremity of this patient. The other extremity was actually normal. Here's some other views here, and you can quickly tell just how small these structures are. They are there. You can find them, but it is hard to see this on MRI. Plus, you got to wait couple weeks for the patient to get the MRI and the result. The ultrasound is point of care right there, which is why we like ultrasound. Why is all of this important? Well, what happens if this goes undiagnosed? This is a common cause of, or a mimicker of lateral epicondylitis. If the patient doesn't get better with lateral epicondylitis, it's probably nerve entrapment. You initially get things like demyelination, inflammation of the nerves, some abnormal bodies start to appear on histology, structural changes, not only in the nerve, but around it in the perineural space. And then eventually the axon gets involved. You can get axonal loss, and then you can get, well, real permanent damage to that nerve. Also, why is this important? Not only do we just not want to miss it in terms of misdiagnosis, different procedures that are out there are starting to come into play. This is the traditional set of treatments that are out there. Just treat them conservatively, get better. They'll get an injection if they don't get better. And if they're still not getting better, you can do surgery. But the whole world of hydrodissection is really increasing. That is a needle coming down, and this black here is an injectate going around, in this case, the median nerve. Here's one of the perineal nerve or fibular nerve, the needle coming right in there and fluid going around. Quite literally, fluid hydrodissection. You're dissecting out any adhesions or scar tissue that's developing around the nerve to try and release some entrapment non-surgically. This is a pretty invasive procedure with a fairly large volume going in. If you don't know your anatomy and you go right at that artery and inject, and you can have a big problem. So this is good to know this anatomy and this potential for abnormal or aberrant anatomy about 15% of the time. Now, as in our typical cases from before, what could I have done better? Well, of course, for this case, I should have recorded a video. I got it on real time, but I didn't. Sorry. I should have shown Doppler. I didn't record that either. I did it real time, but I didn't save it. Darn it. I wish I did. If I completely compressed it, I should have captured an image there just so you can see, although it wouldn't really be very impressive because you wouldn't see anything. I decided to get it where it was partially compressed. This is what it would look like on Doppler. It would just clearly light up, filling with fluid signal, whereas here the nerve just stays, well, static. Also, I could have done a little bit better with the side-to-side comparisons, especially if you're using Doppler. I could have put them like a split screen and done that with ultrasound. Not great with ultrasound yet. I am working on it. My machines are getting better. Soon I'm going to get access to a newer machine, hopefully later this year. So we're going to get some really good digital images and videos coming up soon. To anyone that's out there, if you've seen this or if you have some information on this or you just want to comment on it, I would love to hear about it. Leave it in the comments. I'd love to learn more, and then we can share and all learn together.